I am Rebecca Shrook, Director of Alumni Relations, and glad that you could join us for this evening's online event. Just a few notes before we get started this evening. If you are joining us by telephone, make sure to mute your telephones, and there will be time for Q&A after the presentation, so you could submit the questions through the questions box. Tonight, we are also going to be recording the webinar, and the link for the webinar will be shared in the email that goes out after the event. So without further ado, we would like to continue on, and I'd like to introduce my colleague, Louisa Kopp, Associate Director of Alumni Relations.
Hi, everyone. Thank you again for joining us. Tonight we had over 325 alumni registered to participate. That's making this our largest alumni webinar to date. As you can see from our map, alumni are joining us from across the country and around the world. We have 33 states and 5 countries and territories represented tonight. The Alumni Relations Office hosts events throughout the year and throughout the country. We have networking receptions, sports outings, online presentations just like this one, and we offer all kinds of different programs. Please check our website and your email to see what's coming up in our schedule of events. Even if you're not close to Philadelphia, we may be coming to your way soon. Now I'd like to introduce our speaker. Special thanks to Dr. Charles Pollack for speaking tonight and doing this presentation. He is the founder and director of Jefferson's Lambert Center. But that's only one of his many roles here at Jefferson, which also include the Associate Provost for Innovation and Education and the director of the Jefferson Institute of Emerging Health Professions. Dr. Pollack is a strong advocate for entrepreneurism and innovation in healthcare. We're very happy to have him here tonight and to talk about Jefferson's pioneering endeavor into medical marijuana. Without further ado, I'm going to hand the presentation over to Dr. Pollack. Oh, wait, but first, I think Dr. Pollack, should we do the polls now? Is that okay?
Sure, we can do that.
Okay, so we have a couple of questions we just wanted to ask so that we can see who here is residing in a state that has approved medicinal marijuana, and if you are a physician, if you've ever had to, if you've ever written a script for medicinal marijuana or recommended it.
I'm going to give a little bit more time to let a few more people answer the first poll, and then we'll go on to the second one. But it looks like we have an overwhelming 68% that are yes in a state that has approved medicinal marijuana. So I'm going to close that poll so everyone can see the results for that poll. And then our second poll is, hold on, here we go. If you are a physician in a state that has legalized medicinal marijuana, do you recommend it to your patients? And I'm going to close that poll. About 52% of you voted, so that might be how many physicians we have in the room tonight. But it looks like we're a little bit more split. We have 16% that currently do recommend, 33% at no, and 51% I might recommend it in the future. So we're not sure how those numbers may change after the presentation tonight, but I will give control over to our esteemed presenter. Thank you so much.
Thank you, Louisa. It's Charlie Pollack here, and I'm looking to make sure I can control this somehow. Louisa, I don't seem to have, my mouse is moving there, but I don't have the slide advancer. Why don't you go ahead and go to the next slide?
There we go.
Oh, there it is. Okay, that's what I was looking for. Now I've got the controls.
Right.
Oh, and then they went away again.
Sorry about that.
Okay. That's okay. Technology is a wonderful thing, except when it doesn't work. So welcome, everyone. I'm not surprised to hear that this is the largest attendance has been to one of these sorts of gatherings, and I know very few, if any of you, know me. So it's not about me. It's the fact that medical cannabis is a very timely topic. The people in PR at the university refer to it as clickbait. Whenever we put out a press release from the Lambert Center for the Study of Medicinal Cannabis and Hemp, it gets a lot of attention in the news because everybody's interested in this subject, whether they're for it or against it or undecided, whether they're clinicians or lay people, whether they're patients using it or people interested in getting it for their family members. This is a significant issue, and you should be proud, you Jefferson alums, for the fact that your university has stepped out into a space that no other health sciences university has been willing to occupy. I'll give you the history in a few moments, but the Lambert Center for the Study of Medicinal Cannabis and Hemp at Jefferson is the only comprehensive academic center for research, education, and practice in medicinal cannabis. And so I refer to us on this cover slide as the global leader in this space. And the good thing is really not anybody that can challenge us on that. The center lives within something new. It's just started within the last 2 years, and most of you in the call probably aren't aware of the Institute of Emerging Health Professions. We're sort of an education R&D shop, or some people call us educational entrepreneurism. Our job is to identify educational gaps in healthcare and healthcare-related disciplines that we think will need to be filled over the next 5 to 7 years. And we develop and deploy curricula. They may be weekend courses, they may be CME programs or CE programs, they may be master's degrees or doctorate degrees, they may even be fellowships. But we're looking at being first to market to fill those gaps and secure Jefferson's reputation beyond just being an outstanding source of health-related education for the last 193 years, but also to be innovators in that space. Within the Institute, the Center for Medical Cannabis Education and Research, we call it CMCER, which I know is not a particularly elegant acronym, was founded on May 31st, so we're not yet a year old, as the first and still the only comprehensive academic resource for the medicinal uses of cannabinoid therapy in the U.S. And again, there's very little competition worldwide. So we're taking this into areas where no other universities are going. And Louisa, I no longer have the control. The little buttons aren't there anymore. So please, you take over and just go on to the next slide. There it is again. I don't know why it disappears. Anyway, so May 31st till late November. So that's, a little less than 6 months. The center was renamed from CMCER to the Lambert Center, as you see up on the top of the slide, in recognition of a very generous gift from Australian philanthropist Barry Lambert and his wife Joy. They also fund the Lambert Initiative for the study of cannabinoids at the University of Sydney. And although we have a global footprint and we have advisors and members of the center from literally around the world, we are, as you might guess, really focused on what we hope will be a successful rollout of the medicinal cannabis program in Pennsylvania as well, because there are some unique features of the Pennsylvania law that that give Pennsylvania the opportunity to also be sort of first in class or best in breed in terms of supporting research. That being said, the primary goal of the center is to improve the evidence basis and hopefully to enhance the patient experience in this very crowded and controversial space. We're not advocates for recreational cannabis. We're not advocates for medicinal cannabis. Our advocacy is limited to advocating for better science and better practice so that patients then can do better. Next slide. So if we're going to call ourselves a comprehensive academic resource, I feel like we need at least these three components: education, research, and sort of social impact, which we call by the more bulky name Entrepreneurship and Social Impact Initiative. Go ahead. We're at a medical school and a nursing school and a pharmacy school. When we do education, we do a gap analysis first. And I'm also Associate Dean for Continuing Education. So this is kind of commonplace for me to identify an area where there might be a need for new educational programs, and then first we have to do a needs analysis. So the fact of the matter is that most practicing clinicians, physicians, nurses, pharmacists, today receive very little training in the endocannabinoid system or in anything to do with marijuana other than as a drug of abuse. And so the basic foundation for considering to use cannabinoid therapy in your practice is lacking, and I think the poll at the beginning showed that that's an issue. Go ahead to the next slide. So when clinicians are in a state where they're authorized to recommend should they choose to, they often feel unsupported by the lack of traditional work, an FDA phase 1, phase 2, phase 3 development program that they can't rely on. They often feel pressured by patients, or maybe even worse by patient caregivers. And, there's some concern about federal liability and problems with your insurance companies and malpractice concerns. And, geez, maybe the DEA is going to come arrest me, even though I'm working within a state where I'm following the state rules. All of these things really lead to an underutilization of the program in most states where it is rolled out. I don't remember how the map shook out earlier, but neighboring states here, the Pennsylvania program isn't actually running yet, but New York and New Jersey have had really poor success in terms of getting physicians to sign up. I think most of it is because of the issues in that first bullet there, but there are also some who have philosophical objections or religious objections or other social concerns, and they just don't want to get involved, even if their patients are asking for it. Next slide. Most states, I mentioned New York and New Jersey, they do. Pennsylvania, as the program launches, will do this as well. Require state-mandated CME for physicians to recommend cannabis. Remember, you can't prescribe cannabis. It's a Class 1 substance. But to recommend it, first you have to complete state-mandated CME, which is typically 4 hours in length. That's what Pennsylvania is going to have. Some physicians may view this as a barrier to participation instead of as a learning opportunity. They may wonder about the quality of the CME, given that there's so much we don't know about this drug yet, and given that they already have to do other state-mandated CMEs. So many states have these requirements, and it could be a bit challenging and a bit of a barrier to entry again for physicians who might otherwise want to suggest this for some of their patients. And we noticed as we started building the plans for what was then SIMSR, a really significant absence of good and comprehensive CE offerings, physicians and other clinicians as well, that come from an accredited health sciences university. So again, we saw a gap there that we thought we could fill. Next slide. There's also, and I'm sure many of you are aware of this, you probably see it in your practice, a significant lack of consumer education. And the problem is this leads to some unreasonable expectations. I was quoted in the Philadelphia Inquirer last Thursday, I think, the same day that the USA Today had a headline saying that because of a study that's being launched in Israel, cannabis may be a miracle cure for autism. Now this is a phase 3 study that's small and is just starting. And my first response to the Inquirer reporter who asked me about this was that, in my opinion, the words miracle and cannabis should never appear in the same headline, because many patients who are seeking medicinal cannabis have conditions like chronic neuropathic pain or bad seizures or sickle cell disease or other things where they really are quite debilitated from their disease, and regular therapy is not helping them. And so they look at this as a panacea, maybe as a miracle. And I think as responsible clinicians, we need to dissuade patients and their caregivers from having that attitude, because there are very few miracle drugs out there, and I don't think cannabis is going to be one, except in a few specific conditions where it really does seem to work very well and other drugs don't. And probably the best example of that is in certain pediatric seizure syndromes where conventional anti-epileptics just don't do anything, but cannabis does. Unfortunately, those kind of success stories are few and far between. Doesn't stop you from doing a Google search and seeing some pretty miraculous cures on the internet, as well as some pretty bad horror stories about cannabis. And the truth, I'm sure, for most syndromes lies somewhere in between. Next. So what are we doing to address this? Well, we're building a comprehensive suite of professional education programs. In fact, over the last weekend, we taped 4 hours worth of programs. We're going to be putting on the web by the end of the summer state-of-the-art educational programs for all clinicians, and I'm including dentists in that, although Jefferson doesn't have a dental school, so I'm assuming we don't have any dentists on the line. But we want to make sure that the experts in this field who are all working with the Lambert Center are educating our clinician colleagues, not just in Pennsylvania, but around the country, about the best use of cannabinoid therapy, including those cases where we really have no data whatsoever to support it. Autism, by the way, is one of those issues. We will also have those same experts do programs specifically for consumers, which we'll offer online for free, hopefully helping our colleagues around the country with expectation management. And then maybe the most exciting and ambitious thing we're going to do, which is going to take probably a year or two, is in recognition of the fact that most professional health sciences universities don't have curricula in cannabinoid science and the endocannabinoids. We're going to develop that and give it to them in a module that they can sort of drop in to the medical or nursing or dental or pharmacy school, wherever they are, at the appropriate time that they think, so that they don't have to develop that expertise from within. We have the experts bringing that curriculum to them. So we think over time that will start to fill some of the gap in knowledge and comfort that currently exists from even recent professional school graduates. Next slide. So research, we started with the gap analysis. As I mentioned already, and you're probably already aware, there's basically no traditional drug development-based evidence in this space, and it's getting harder and harder to do good studies because of two reasons. One, the public is very impatient, waiting for data on a substance to which many of them already have access. Remember, 29 states and the District of Columbia already allow physicians to recommend cannabis to their patients. Secondly, it's hard methodologically. I don't know how many research-trained people we have on the call, but it's challenging methodologically to do these studies because in both illicit and licit settings, marijuana is available to people who are likely to be enrolled in these studies. And so it's hard to make sure that they're only getting the study material that we want them to have, or that if they're in a placebo arm, that they don't get any marijuana. If you're giving someone medicinal cannabis, you can't drug screen them to see if they're taking cannabis because you're expecting them to take it. So these are interesting issues that we're dealing with as we design research protocols. I think there's also a bit of being overwhelmed by the potential number of indications. It's hard to decide where to focus your efforts because there's so many things you can study with cannabis, and there's so much public demand and basically a lobbying group for every one of them. Next. There's been a lack of prioritization, which we're going to address with a white paper that hopefully will be published by the end of the summer, trying to move the field forward in a consistent direction. There's been a significant lack of quality work. If you look at the literature, and you can't see me right now, but I'm putting air quotes around that term, literature, is really dominated by case reports and case series, underpowered studies, anecdote, things that we would ordinarily not base our practice on. And that's a bit frustrating if you want to be serious about this and see if you can use it to help your patients. Next slide. There's also a lack of consistency, and part of that is because of the federal rules governing marijuana research. There's only one source of plant material that can be used in clinical trials in the U.S. That's the NIDA farm at the University of Mississippi. And they don't have limitless stores of this drug. Every hospital that studies it has to have a Class 1 DEA license, which can take months to obtain. Even if you have a multi-center study where different sites have all that license, they get the material, over the course of a year or two, there's grow-to-grow variation in the plant. This is truly a botanical drug. And so there are, again, lots of methodologic issues that have led to the lack of good data already in the literature. And then finally, for reasons primarily dealing, again, with federal regulations and availability of research material, it's been hard to achieve scale to do the kinds of studies that we'd like to do to try to answer some of these questions more specifically. Next. So what are we doing? I mentioned a moment ago, we're developing the first ever prioritized research agenda for medical marijuana. It will be published by the end of the summer in the Journal of Cannabis and Cannabinoid Research, which is the only peer-reviewed journal that's dedicated to this space. And in case you're interested, it is open access. So cannabis and cannabinoid research, you can start looking for articles coming out there if this is a space that interests you. We can't do even a fraction of all the studies that need to be done just at Jefferson. We will be doing cannabis studies at Jefferson. But through the Lambert Center, we've aligned ourselves with a number of other collaborating institutions and companies both within and outside the U.S. And so look at us as a networking nidus, looking at all sources of cannabinoid material, whole plant marijuana, marijuana extracts, cannabinoids derived from hemp. You see the hemp in our name there. And also synthetics, as we have the opportunity to study them. We want to make sure we do whatever we can to advance the science in this field. And we'll start with the areas that we think need the research the most and the most quickly. And those are particularly around PTSD and pain control. Our goal, again, is to bring scientific rigor to a space that has very little these days. Next slide. Next slide, please, Louisa. So in practice, there are more issues and inconsistencies that we can count in this space. And it's because you've got 29 different laws, all of which, by the way, if you don't remember, are in contradiction to federal law that set up these programs that determine what types of materials can be sold in dispensaries, who works in dispensaries, whether the material can be smoked, whether it has to be eaten, whether it can be topical. And there's a significant lack in most states of physician oversight and specific protocols for care. Now, that may be unfair to say because without much evidence, you can't really develop an evidence-based protocol. But nonetheless, there's a lot of inconsistency in this space. And we want to try to dampen some of that by developing some best practice models. Next. The practice part of our center is referred to as the entrepreneurship. No, we can go back to there. It's okay. The Entrepreneurship and Social Impact Initiative, or we call it SI. We'd like a better name, but that's what we have so far. Looks at the entrepreneurial side of this because, generally speaking, this is like a gold rush around the country. It's the fastest growing market sector in the United States right now, medical marijuana. And there are also social impacts that aren't well understood, have been arbitrarily designed, and impact inclusion and sustainability in this industry. And we can't fix those, but we do want to shed light on them in an academic and systematic way. Next. So our first efforts from the SI side of the Lambert Center are to develop best practice papers, business practice, dispensing practice. We have some pretty powerful partners. We've already aligned ourselves with the Brookings Foundation, and we're also working with a number of other think tanks, including Pew, and others that are starting to move into this space. They welcome having an academic presence there, and we'll do things with our presence like develop white papers and position papers on how to staff a dispensary, how to train patient-facing personnel, and how best to educate physicians in this space. There's also a big issue around veterans' access to cannabis. Because cannabis is a Class 1 substance, federal employees, like every doctor who works in the VA, are specifically prohibited from talking to their patients about these substances. And whether or not it would help them, they take umbrage to that, and that's something we want to try to look at as well as a way to sort of work around that restriction. Next. So we also will be developing some business plan and idea competitions, which hopefully you'll read about if you visit our website on a regular basis. Workforce development is an important issue. We're trying to link it to some welfare to work programs. But the fact of the matter is in Pennsylvania alone over the next 15 months or so, there are going to be thousands of new jobs created. And we want to make sure that the people who most need those jobs and can be qualified for those jobs have the opportunity to get them. So we have a real social mission here that was often missing from Jefferson's perspective when we were just a health sciences university. As I'm sure all of you on the call know, effective July 1st, we have an undergraduate campus, and we have undergrads, and we have business students, and we have social science students, and we're going to take advantage of those in work done by the Lambert Center. Next. So that's a quick introduction to a center that has gained remarkable visibility in just 11 months. I think it's very good for our institution. Again, I want to reassure any of you who are concerned that we're not taking any sort of advocacy position here. We're simply working with what the states have done with their laws and then trying to bring science into alignment with what politicians are telling doctors and nurses and pharmacists they can do. So it's a very exciting time. It's a lot of fun for Jefferson to be at the forefront of this. In the last week, I've had direct conversations with the Deputy Commissioner of the FDA and the Deputy Director of the DEA. They are all so excited to have a prestigious health sciences university involved in the space because they're used to dealing with people who aren't quite as serious about the research they're proposing. So I'm happy to take any questions you have. I would refer you the next slide, I think, has the website for the center. Take a look at it from time to time. Again, by the end of the summer, they'll be posted their links to CE and CME accredited educational courses. And there'll also be links to patient materials to which you can refer your patients if you choose. So I'm looking over in the little box here, and I don't see any questions yet. I'll turn it back over to Louisa, and she can ask for questions in maybe some other way.
Yep, it looks like they're coming to me over here, so I'll just read them off to you if you don't mind answering them. So one of the first
I can't say that yet. I'll have to see.
Yeah. So we'll see. The first one we have here are from Michael Lewitt. What are the differences in THC content that have an impact on medical as opposed to euphoric results?
So this is a great question. As far as we know right now, let me preface what I'm about to say by saying that there are at least 140 biologically active compounds in marijuana. Based on what we know so far, and as you might guess, there's a whole lot still to learn, the most and potentially the only psychoactive component is delta-9 tetrahydrocannabinol, or delta-9 THC, it's just called THC. That's an important distinguishing characteristic between marijuana and hemp, both of which are genus Cannabis and species Sativa. Hemp, as defined by the DEA as so-called industrial hemp, even though it yields medicinal substances, has less than 0.3% by volume THC, which means that if you smoke or ingest or apply a hemp-derived cannabinoid to your body, you will not get high. There's no psychoactive effect of that. Marijuana contains varying amounts of THC. Back in the 60s and 70s, when marijuana first became common on college campuses, the typical THC content of marijuana that was smoked at that time or baked into brownies or hash or whatever was typically about 6 to 10%. And now if you go to dispensaries in Colorado, recreational dispensaries, not medicinal dispensaries, so head shops basically, you can get THC content up in the 40s and 50s. It's remarkable, and they are extremely intoxicating at that level. From the medicinal side, there are some illnesses for which marijuana is touted, for which THC is needed, and some for which it isn't. There's a lot of debate right now whether or not you actually need THC to use marijuana to treat PTSD. Many pain syndromes, though, do require, it seems, based on limited data that we have, THC in addition to the other cannabinoids, which means that maybe we'll get to a point where seizures of PTSD can be treated with hemp only, which gets around some of the regulatory concerns that currently exist around using marijuana, which does have THC in it. But to treat other syndromes, you're going to need THC, and that's one of the many questions we're seeking to answer, is just where do you need that psychoactive component? Because from a societal standpoint, obviously whenever we can get away without using the psychoactive component, we'd like to.
All right, great. Now moving on from Nina Lerner, we have the question, how can prospective employees best handle pre-employment drug tests when being prescribed medical marijuana?
Great question, Nina, and unfortunately, you need a lawyer to answer that, not me. And it's going to vary from state to state as well. You know, for a long time, we've had drug tests that look at things like opioids and benzodiazepines. And if you, with most employers at least, if you take in documentation that a physician has ordered or prescribed these medications for you, then they are not allowed to hold that against you. Given that marijuana, though, which of course shows up very readily on urine drug screens, is a federally illegal substance, even in states where it's been approved, there could be some employment law issues that could be very vexing. That's not something I can really comment on, but it's a great question, and again, the answer I think will vary from state to state.
All right, so moving on, we have from Ethan Wasserman. Can you discuss resources that are available that discuss data for use in oncology indications?
So one of the modules that we're building for our comprehensive menu of educational courses will be on cancer. There's basically no rigorous scientific data that suggests that marijuana impacts the clinical course of the malignancy itself. There are some interesting studies about certain cannabinoids causing apoptosis of cancer cells, but I don't think that's really going to pan out, at least not at this point. Generally, cannabinoids are used in cancer patients to treat pain or to treat persistent nausea and vomiting associated with chemotherapy. This is one of the areas where it has been studied fairly rigorously, and we have a gentleman out at UCSF named Donald Abrams, who's probably the world's expert on this, who's doing the educational module for the Lambert Center courses in this space. And at this point, all I can tell you is they'll be available by the end of the summer and hopefully sooner.
Great. Here's a great question from Dr. Harry Sachs. What role do you see nurse practitioners playing?
Well, that varies from state to state. Pennsylvania actually does allow nurse practitioners to work in dispensaries. Pennsylvania, by the way, is one of only 4 states that requires that the patient-facing person in a dispensary be a clinician. There has to be a pharmacist employed by the dispensary, but if they need it for staffing, they can have a physician, a nurse practitioner, or a PA there. Most states don't specify that. But again, in Pennsylvania and a handful of other states, NPs, NPAs will have a specific role should they choose to accept it. So again, I have to refer you to wherever you are, your specific state rules on that.
Great. And then S. Robert Friedman asks, will you be studying non-medical recreational use?
No, we are, we're the first and only health sciences university doing this level of work for a reason. There can be some very unwelcome federal scrutiny that comes with doing this work. And one of the reasons or one of the ways we're sort of insulating ourselves from that, as you heard earlier, I'm literally talking on a regular basis with very high up people in the DEA and the FDA. One of the ways we're maintaining our comfort level in this space as far as they're concerned is by scrupulously avoiding any recreational work. Now, we may be looking at some toxicity issues along the way because some of what we know about the toxicity of cannabinoids that may be used in medical settings actually comes from the recreational world. But we won't be doing any studies on recreational use or on cannabis use disorder. We think those are important, but that's not where we're focusing our efforts.
Perfect. I just thought it bared repeating. So let's see. We have a question from Kanani Tichin, who asks, can you please comment on cannabinoid hyperemesis syndrome and any research planned in this area? I'm sorry if I totally butchered that pronunciation.
Yeah, cannabinoid hyperemesis syndrome. We're seeing more and more of that, and it's generally associated with recreational use of high THC preparations. I'm an emergency physician, for those of you who heard me introduce at the beginning, and we tend to see this in the emergency department, and we're seeing it much more commonly than we used to, and it's again because the concentrations of THC in recreational pot are so much higher than they used to be. Generally speaking, just withdrawal from the substance will take care of it, but patients may well need IV fluid resuscitation. They may need antiemetics. One of the interesting things about cannabis hyperemesis syndrome is that having the patient stand in a steamy hot shower will often make the patient feel a lot better. And so that's something that you might want to keep in mind if you have an office-based practice or if you're in an emergency department and somebody calls in and describes something that sounds like it might be cannabis hyperemesis before they come trucking into the emergency department at 2 or 3 in the morning. You might suggest they stand in a really hot shower and see if they feel better.
Great. And now let's see, from Carl Fatkenhauer, he asks, will you utilize and require output from marijuana analytical labs?
For some studies you need very precise toxicologic and analytical labs. For others you don't. It's purely clinical. That'll be on a study-by-study basis. We already have some relationships with some labs that are out there and have demonstrated their expertise. But again, that's going to vary depending on the specifics of the study.
Great. And then from Luann Vanaman, first she has a comment that says, congratulations on leading the effort in this field. And her question was, is there any science which focuses on the addictive quality of cannabinoids or hemp?
Absolutely, there is, and thank you for your compliment first. There's a whole new field out there now with so much more cannabis. There's always been illicit cannabis use. Now there's so much licit cannabis use, and it's in populations because of the medicinal applications that we really haven't seen using cannabis before. But there is a psychiatric diagnosis now called cannabis use disorder, or CUD, C-U-D, and that is getting a lot of attention with federal funding from NIDA, the National Institutes of Drug Abuse, and a lot of foundation funding as well. Interestingly, and maybe not surprisingly, some socially active groups that don't believe in medicinal or recreational marijuana are paying for some of this research. So it's the work's getting done for a number of reasons. Marijuana is a drug of abuse. It is addictive. Some patients are much more likely to become dependent on it than others. But it is addictive in the same way that opioids and nicotine are. There are many patients who can use marijuana on an infrequent or even regular basis and never develop dependence or an actual use disorder. There are others who, with minimal exposure, start to develop problems. So, like many things to do with substance abuse, we don't fully understand why it happens and why there's so much patient-to-patient variation. But indeed, there is a specific amount of work going into this problem with cannabis.
Great. From Joseph Tan, we have the question, is there any research on use of marijuana in the field of ophthalmology?
So one of the earliest touted uses for cannabinoid therapy, and at that time we didn't even call it cannabinoid therapy, it was just marijuana, was in the treatment of glaucoma, because it was found back in the 70s that the use of marijuana actually decreases intraocular pressure, which of course is one of the manifestations of glaucoma and one of the things that can cause blindness in glaucoma if it's sustained. Marijuana actually does very nicely and in dose-related fashion reduce intraocular pressure. The problem is that the effect is very short-lived. Topical doesn't seem to work. Most of the literature we have is from smoked marijuana. And to maintain the reduction in intraocular pressure that marijuana brings about after you smoke it would require basically constant smoking or very frequent smoking that would probably disable patients for other reasons. So although in many states glaucoma is one of the qualifying conditions for which medical cannabis can be recommended, there's really a pretty shallow evidence basis behind it. We hope to work with our friends across the street at the world's premier ophthalmologic center, Wills Eye, to do some work in this area, but the study hasn't been designed yet. That's on the short list for the next couple of years.
Great. Let's see, from Sibbon Stephen, the question, does the Lambert Center currently work with Greenwich Biosciences and their clinical studies?
Yeah, I'm not really at liberty to say who all of our partners are, but we do have a wide variety of both education, foundation, and for that matter, private enterprise partners.
Okay, Joan Smith asks, will any of your research involve effects of non-medical marijuana use on pregnancy and fetal effects?
That's not something that's on our radar right now. Again, this is a wide open universe with more questions and studies that we could ever do. And again, we're focused really on the medicinal side and not the recreational side, even the toxicity of the recreational side. There's enough for us to do on the medicinal side. So I think that's of interest, but it's probably not something that's going to reach our priority list anytime soon.
Okay, and then we had a comment from Dr. Harry Sachs, who mentioned that his wife had stage 3 ovarian cancer and could not have gotten through her chemo without medical marijuana. So thank you for this work.
Well, you're welcome, Dr. Sachs. And we hear those stories all the time. And as I said earlier, one of the areas where it seems like appropriate doses of cannabinoids really are helpful is in complications of cancer. Sometimes it gets conflated to where people think that marijuana is actually treating the cancer. That's unfortunately not the case. But in terms of managing the pain that the cancer can cause and the side effects that anti-cancer drugs and therapies can cause, it may in fact be pretty helpful.
Here's a great question from Michael Sigler. On a less scientific note, can you please address malpractice insurance implications for physicians who choose to either discuss marijuana use therapy with patients or wish to become referring providers? And thank you for bringing such an important topic. Such an important topic in modern society and medicine to Jefferson and for our webinar tonight.
Well, you're welcome. And another great question that's sort of like the employee law issue. It's going to vary from state to state, and in this case from insurer to insurer. We have heard of cases where insurance companies that tend to be smaller, not the big Blues or Aetnas or something like that, but some smaller insurance companies have asked their physicians not to recommend marijuana. That's not a decision based on science any more than asking their physicians to recommend marijuana is. The flip side of that is that because it's a Class 1 substance, no insurance companies, and certainly not Medicaid or Medicare, cover cannabinoids. So these are generally out-of-pocket expenses for patients. It's again a challenging area, and one of the reasons that some physicians in some states have said I'm not going to participate is because they're worried that they might get sued or they might get arrested or all sorts of things that sound a bit apocryphal, but are actually feasible. We don't hear anything about it though. The DEA actually doesn't has never to date enforced a Class 1 felony on a physician who has recommended marijuana under a state program. So, precedents can be broken, and in the current political landscape, I guess nothing is secure anymore. But generally speaking, that's not a big problem, and we haven't seen a whole lot of problems with malpractice insurance.
Okay, great. And I just got a few questions that were asking about the Lambert Center, the Lambert story, about what inspired them to make a gift and start the center.
Yeah, it's a very like many stories in the cannabis space. It's one driven by personal experience and personal passion. Barry and Joy Lambert are grandparents of 11 grandkids. I've met them all. They're lovely people. One of their granddaughters, one of the younger ones, name is Caitlin. You can see a little picture of Caitlin on our website. Caitlin, at age 2.5, was diagnosed with Dravet syndrome. For those of you who aren't familiar with that, that's one of the most horrible pediatric seizure disorders. She was having literally hundreds of seizures a day, spent as much time in the hospital as out of the hospital the first couple of years of her life, and was becoming so debilitated that at age 2.5 she couldn't even hold her head up. Was completely nonverbal, was not crawling. I mean, it was clear that she was going to have a poor outcome, which is typical of Dravet's. Also typical of Dravet's, traditional anti-seizure medication did not help her. She had breakthrough seizures constantly. And her father, who's Barry's and Joy's son, actually was able to obtain some cannabis from Europe because it wasn't available in Australia either. Within a couple of doses of hemp-derived cannabinoids, which is one of the reasons why hemp is in our name now in the center's new name, Caitlin became seizure-free. And in the last 3 years now, she's remained almost completely seizure-free, is now going to school. She's behind where she should be for age, but she's going to school. She's much more verbal. She's very active and playful, and it's just a wonderful thing to see. Dravet syndrome does often respond to cannabinoid therapy. Unfortunately, it doesn't always respond. But in Caitlin's case, she did respond very well, and that inspired the Lamberts, who had made quite a bit of money in the financial service industry in Australia, to share some of that first with the University of Sydney to study cannabinoid therapeutics, and then subsequently to establish sort of a North American beachhead of their philanthropic work at Jefferson.
Wonderful story. So let's see here, going through a few more of our questions. I think we probably have room for maybe about 2 more. Let's see. Depending on what your research and collaborators' work discover, can you see a day when Jefferson University Hospital uses medical marijuana in-house as is used in wards in Israel?
Yeah, that's unfortunately not really a clinical question. It's a legal question. And right now, no hospital in the U.S. is using cannabinoids because they risk losing their CMS and NIH funding if they do that. So it's not really a question of whether the data support it or not. It's a question of when will the law change. So, there are all sorts of concerns about people bringing in their own or caretakers bringing it in and security of that substance. This is a really sticky wicket in terms of managing patient safety, and you may have providers in the hospital who don't believe in medicinal cannabis and don't want their patients to have it. It's really quite a mess, but right now we can all fall back on the fact that the federal government doesn't allow us to have it in the hospital anyway.
Right. All right, let's see here. Here's actually a clinical question. Are you going to be able to do placebo-controlled, double-blind studies so that placebo patients will get the euphoric effect?
So there are, from the Night Farm in Mississippi, there are cannabis placebos that smell and taste like marijuana without having cannabinoid effects. They seem to work fairly well. The biggest issue is not in the placebo that's being given as part of the study. The biggest issue is that patients who are in the study typically have fairly easy access to street pot or even going into a dispensary if they live in a legal state. And getting it there. So the problem isn't so much having a good placebo. The problem is keeping patients from self-medicating when they're in a study that doesn't really doesn't really allow that.
Okay. Diane Yoakum asks, will your research include autism and medicinal cannabis?
Yes, I can't tell you when we'll start that, but that is an issue of great interest. Pennsylvania is the first state to include autism specifically as a qualifying condition in their cannabis law. Other states have referred to syndromes in kids that kind of look and smell like autism, but they didn't actually use the word, which of course is very socially charged. I mentioned earlier a headline in the USA Today last week about a new autism study in Israel that has just launched. We do have that on our agenda, and I think it'll be on the front end more than the back end.
Then we had two guests ask kind of in the same vein about, I'll read both questions and see if you can combine the answer, but one asked, how common is cannabis use and activation of psychotic disorders? And Joseph Tan also asks, are there any known long-term side effects of cannabis on a person's behavioral and cognitive faculties?
Yeah, those are probably not great questions to ask at the end of our time together because they each could take a half an hour to answer. What I will tell you is that with respect to the second question, the biggest concern about long-term effects on behavior of cannabis really come into play with patients who have psychiatric disease that may be clinical or subclinical when they start using marijuana, but particularly in the time of the so-called plastic brain, which is basically ages 12 or 13 up to 25. We really want to, based on the best available evidence we have now, limit cannabis exposure as much as possible until age 25 when the endocannabinoid system is fully formed in the brain. That's tough to do. That's when kids are in college, and that's a challenge. That's a social issue that I wish I could fix, but I can't. I've got 2 kids in college and one about to go there. The effects are most long-lasting when there's regular use, not occasional use, but regular use during those ages. With respect to the first question, it's really quite interesting because back in the 80s and early 90s, there was some data that looked, fairly interesting. We've since sort of moved away from it, but suggesting that cannabis use actually caused schizophrenia and acute psychosis. And the current thinking by people who are a lot smarter than I am in this space is that that's not true. That's not causative, but that the THC in marijuana may well unmask subclinical schizophrenia or psychosis and bring it to the fore in association with that use, making it look like it's causative and certainly can make it worse.
All right, and then I guess here, hopefully this should be a short, quick question to finish out the Q&A. Luann Vannemon asks, will the clinical trials be listed on clinicaltrials.gov?
I might lose my job if they aren't.
Right. All right, well, for everyone that we didn't get to, perhaps we can compile the questions and send them along to Dr. Pollack. And then, of course, on your screen is the website for the Lambert Center to find more information. As we finish out the night, I'm going to give it back over to Louisa. But Dr. Pollack, thank you again for joining us this evening. This was a great event.
Great. I'm glad everybody can make it. I hope you learned something. And again, I hope no matter what your personal position is on recreational use, medicinal use, recommending to patients, I hope you have some measure of pride that the Jeffersons out there really making a difference in this space that no other medical schools really wanted to tackle.
Thank you again, Dr. Pollack, and everyone who participated tonight. I hope you enjoyed our presentation, and I hope also that you'll take a look at our other alumni events that are coming up. We'd love to have you join us either online or in person. We offer 65 events throughout the year in the Philadelphia area and around the country, and we also offer a variety of other kinds of programs and services for our alumni, including opportunities to get involved. So check back on our website to learn more. We're planning to do more of these online seminars. In fact, we're planning one for June. So keep an eye out for that. And if you have any recommendations for topics that you'd like to see, let us know. Again, thank you all for participating, and have a good night.
Thank you all, and as I said, this webinar has been recorded, so please look in your emails for a link to the webinar. Feel free to share, and as Louisa mentioned, please feel free to reach out to us with any questions. Thank you again for spending an hour with us on this Tuesday night. Have a great night, everyone.